We'll speak about acute kidney injury. Acute kidney injury. So we have pre-renal, and post-renal azotemia. So pre-renal and post-renal and intrinsic renal failure. So we have pre-renal, post-renal, and intrinsic. So pre-renal means what? There is decrease in the blood reaching to the kidney. Decrease in the blood reaching to the kidney, like what? Hypovolemia, decrease cardiac output, or decrease effective circulating volume, like what? If there is heart failure, so there is a decrease in the blood reaching to the kidney. If there is liver failure, it's called what? It's called hepatorenal syndrome. If there is liver failure, so there is what? There is severe vasoconstriction of the blood vessel of the kidney, leading to decrease the blood supply to the kidney, leading to kidney injury. So pre-renal, acute kidney injury, pre-renal azotemia. So there is what? Decrease in blood supply to the kidney, like hypovolemia, decrease cardiac output, or decrease effective circulating volume. In case of heart failure, decrease the blood reaching to the kidney. And liver failure because of hepatorenal syndrome, hepatic failure, leading to severe vasoconstriction of the blood vessel of the kidney, leading to acute kidney injury, pre-renal azotemia. So pathophysiology, there is what? Decrease in the renal blood flow, decrease glomerular filtration rate, leading to what? Activation of RAS system, renin angiotensin aldosterone system, leading to sodium reabsorption, potassium and hydrogen loss. So if there is reabsorption of the sodium, so the water follows sodium, leading to reabsorption of the water, plus there is reabsorption of the urea. Urea has osmotic effect, leading to reabsorption of the water. So reabsorption of the sodium and loss of potassium and hydrogen. Reabsorption of sodium, water follows sodium, leading to reabsorption of the water, plus reabsorption of the urea has osmotic effect, leading to water reabsorption. Then the main difference between the pre-renal and intrinsic is what? If there is affection of the tubule or not. So intrinsic, there is damage to the tubule, but in the pre-renal, the tubule is normal, but there is decrease in the blood supply to the kidney. So regarding the tubule, it's normal in pre-renal azotemia. So there is what? There is sodium reabsorption, potassium and hydrogen loss, sodium reabsorption. So water follows sodium, so reabsorption of the water. So there is decrease in the water in the urine, decrease of water in the urine, leading to elevation of your urine osmolarity more than 500, because there is reabsorption of the water. So there is decrease in the amount of water in the urine, leading to elevation of urine osmolarity more than 500. Then the tubule is normal, so there is the reabsorption of the sodium. So there is a decrease in the amount of sodium in the urine, because there is reabsorption of the sodium. So the urinary sodium will be less than 20. Then fractional excretion of the sodium less than 1. Why? Because there is reabsorption of the sodium. So there is decrease in the amount of the sodium in the urine. So less than 20 urine sodium less than 20, fractional excretion of sodium less than 1. Then serum bun and creatinine. We said that in pre-renal the tubule is intact. So there is reabsorption of the bun. So bun creatinine ratio more than 20. Why? Because there is more reabsorption of the bun. So the tubule is intact. So normal reabsorption of the bun. So the bun creatinine ratio will be more than 20. Then the next one, intrinsic. Intrinsic, we have causes that will affect tubule, glomerulus, and vascular. So tubule and interstitium. The main one is what? Acute tubular necrosis caused by ischemia and nephrotoxin. But the main one is what? Ischemia causing what? Acute tubular necrosis. Acute tubular necrosis appears like what? Granular muddy brown cast. Acute tubular necrosis due to ischemia. Appears like what? Appears muddy brown cast, granular muddy brown cast. This is acute tubular necrosis that will cause intrinsic renal failure. Then we have what? We have acute interstitial nephritis. So what are the causes of interstitial nephritis? These causes are so important. So we have 5Bs. We have diuretics, pain-free non-steroidal anti-inflammatory drug, penicillin, cephalosporin, proton pump inhibitor, rifampin, sulfa drug. So these drugs are so important. These drugs will cause what? Will cause acute interstitial nephritis. So the first one is what? Diuretic, non-steroidal anti-inflammatory drug, penicillin, cephalosporin, proton pump inhibitor, rifampin, sulfa drug. So diuretic, non-steroidal anti-inflammatory drugs, penicillin, cephalosporin, proton pump inhibitor, rifampin, sulfa drugs will cause what? Will cause acute interstitial nephritis. Then the glomerulus, there is acute glomerulonephritis. So vasculitis, malignant hypertension, TTP, HUS, thrombocytopenic purpura, hemolytic uremic syndrome. So all these causes leading to what? Leading to intrinsic cause of the kidney. Maybe tubule, acute tubular necrosis, maybe glomerulus, acute glomerulonephritis, maybe vascular, like vasculitis, malignant hypertension, thrombocytopenic purpura, or hemolytic uremic syndrome. So we have acute tubular necrosis due to ischemia. This is so important. Granular cast, granular muddy brown cast, and acute interstitial nephritis. And we said the causes: diuretics, non-steroidal anti-inflammatory drug, penicillin, cephalosporin, proton pump inhibitor, rifampin, and sulfa drugs will cause what? Will cause interstitial nephritis, acute interstitial nephritis. So we said that in intrinsic, this is the tubule, there is damage to the tubule. So in acute tubular necrosis, in intrinsic cause, patchy necrosis, leading to formation of debris. This debris leading to what? Obstruction of the tubule, and fluid backflow leading to decreased glomerular filtration rate. So there is what? There is necrosis leading to formation of debris leading to obstruction of the tubule because of this necrosis. So there is affection of the tubule, there is abnormality in the tubule, there is malfunction in the tubule, there is no reabsorption from the tubule. So leading to what? Debris because of necrosis, leading to obstruction of the tubule and fluid backflow and decrease in glomerular filtration rate. So there is the tubule will not do its function. So there is no reabsorption of water, there is loss of water in the urine, leading to what? Decrease the urine osmolarity, plus there is no reabsorption of the sodium, leading to loss of sodium inside the tubule. So the urinary sodium will be more than 40. Then there is no reabsorption of the sodium, so the sodium will increase inside the urine, so fractional excretion of sodium will increase, plus there is no reabsorption of the bun. So the bun creatinine ratio will decrease. Why? Because it's bun creatinine ratio. So in the first cause, pre-renal, the tubule is intact, so there is normal reabsorption of the bun, so the bun creatinine ratio will be more than 20. But here there is affection of the tubule in intrinsic cause, so there is no reabsorption of the bun, so there is decrease in reabsorption of bun, so bun creatinine ratio will decrease less than 15. Then the last one is called what? Post-renal varies means it's maybe intrinsic and maybe pre-renal. So it's what? It's a combination between both types. It's a combination between both types. So maybe intrinsic and maybe pre-renal. So post-renal, there is what? Obstruction, outflow obstruction, bilateral, outflow obstruction, bilateral, and varies according to the urine osmolarity, varies according to the urine sodium fractional excretion of sodium, bun-creatinine ratio. So you must know what? Intrinsic and pre-renal and intrinsic, and you must know the secret of it. What is the secret? In the pre-renal, the tubule is intact, but in intrinsic there is abnormality in the tubule, there is necrosis in the tubule, so there is no function of the tubule, in post-renal, maybe intrinsic and maybe pre-renal. So post-renal, there is outflow obstruction, bilateral, and varies in everything, in urine osmolarity, in urine sodium, fractional excretion of sodium, and serum bun-creatinine ratio. So this obstruction is caused by what? It's caused by a stone, benign prostatic hyperplasia, or neoplasm, or congenital anomalies. So it's caused by stones or benign prostatic hyperplasia, neoplasm, or congenital anomalies. Then the next one, acute interstitial nephritis. So you must memorize these drugs leading to acute interstitial nephritis. So you have what? Diuretics, non-steroidal anti-inflammatory drug, penicillin, cephalosporin, proton pump inhibitor, and rifampin sulfa drug, and it's associated with what? Fever, rash, pyuria, and hematuria, plus costovertebral angle tenderness, but can be asymptomatic and may be associated with what? Fever, rash, pyuria, hematuria, costovertebral angle tenderness. So what's meant by acute interstitial nephritis? It can be called tubulointerstitial nephritis. So tubulointerstitial nephritis is the same as acute interstitial nephritis. So acute interstitial renal inflammation. So pyuria, mainly eosinophils. So eosinophils, interstitial equals what? Eosinophils. So acute interstitial nephritis, tubulointerstitial nephritis, acute interstitial renal inflammation with pyuria, with eosinophils, it's interstitial nephritis, eosinophils, azotemia, then occurring after what? Administration of the drugs. And we spoke about these drugs. Why these drugs? Because they will act as haptin. Haptin is a type of antigen. It's like antigen. So the antibody will attack it, leading to what? Hypersensitivity. So these drugs will be treated as what? Will be treated as what? As haptin. So haptin is like antigen. So the antibody in the patient will attack what? Will attack this haptin because it's a foreign antigen. So antibody attack for it, leading to hypersensitivity. So the drugs like what? Diuretics, non-steroidal anti-inflammatory drug. So diuretics, non-steroidal anti-inflammatory drug, penicillin, proton pump inhibitor, rifampin, quinolones like ciprofloxacin, levofloxacin. So you have quinolones, ciprofloxacin, levofloxacin, and you have sulfonamide. Less commonly may be due to secondary cause, secondary to what? Systemic infections like mycoplasma or autoimmune disease like Sjogren's syndrome, autoimmune attack for the glands, for the salivary glands. So Sjogren syndrome, systemic lupus erythematosus, there is degrees in what? In C3 and C4, degrees in the complement, and sarcoidosis, there is what? There is non-caseating granuloma, So we have a secondary cause to what? To systemic infections, mycoplasma or autoimmune disease like Sjogren, systemic lupus erythematosus, or sarcoidosis. But you must know these drugs, they will act as haptin. Haptin is like antigen. So the antibody attack for it, leading to hypersensitivity, leading to interstitial nephritis. So the last one is what? Is these drugs. We will say it: diuretics, non-steroidal anti-inflammatory drugs, penicillin, cephalosporin, then proton pump inhibitor, rifampin, and sulfa drug, leading to what? Acute interstitial nephritis.